You can ask the flowers. I sit for hours telling all the bluebirds.
Hi everyone, this is Holiday with Birth Milk, and I'm going to go over my favorite resource as a birth doula and labor and delivery nurse. So this resource is called spinningbabies.com, and whether you're a nurse, nursing student, birth doula, parents, families, anyone can access this resource. And one of my favorite things that I'm going to show you on the website is techniques and then positioning to kind of understand both and how they relate to each other. So just to quickly go over so you understand a little bit, is techniques are positions we can do in labor to help, I use the word move the baby. Spinning babies might use a different term like relax the uterus to give it more room for the baby to move in it. Whatever terminology they use, what I like to use is move the baby. And how that is done is relaxing ligaments, giving a little more space, a ton of different things. So a lot of these positions, you're going to be like, wow, this looks a lot like, kind of like a really cool yoga. And that is true. And some of them look like, whoa, that is totally new. And that is also true. And what's great about spinning babies is when you look on the website, which I'll be showing you in just a second, and you go to techniques, you can go to the position and they will tell you like when to use that position, why you would use that position, and any contraindications like why maybe you shouldn't be doing that position in labor or while you're pregnant. So that is a really cool tool and part of Spinning Babies, and I'm going to show you right now.
When you get to the Spinning Babies website, so you just put in spinningbabies.com, you actually want to look at I'm looking for, and this is, honestly, you want to really go through all of this. All of this is some amazing stuff, but what I'm specifically looking for right now is techniques. Techniques is where the positions are going to be. Now, Spinning Babies has its own names for its positions, and some different like bundle birth might have some differing names for the same positions, but here you have your 3 balances, which is a rotation of the jiggle, forward leaning inversion, and sideline release. It will tell you like why to use this. It will tell you common contradictions for this when you don't want to use it, and it will kind of give that feedback for all of these positions that you may have. One of my favorites is forward leaning inversion. And then you can also go to other techniques right here, and you'll get into far more options. So right over here is flying cowgirl, which is one of my favorite positions. And then Walters is always a good one to do as well. But please read the why you do it, when you do it, and contradictions for it.
So now that you've kind of seen techniques, I'm going to actually show you the position section on spinningbabies.com. So Spinning Babies has a whole page on, the position of the baby in uterus. So there's OA, there's OP, and there's variations of those that I'll be showing you how to get to on their website. As a nurse, as a nursing student, as a birth doula, or in this kind of field, I really feel like you need to understand what these positions are, what are kind of good positions, what are not so good positions, and how to connect that with positioning techniques we can do while in labor and delivery to kind of put that baby or give that baby the opportunity to be in the more ideal position like OA or some variation of OA. So I'm going to show you that right now.
So leaving the techniques, you're going to go back to I'm looking for, and what you want to go down to is baby positions. Baby positions is a section of the website that will show you the position of the baby. Like you can see that here we have an anterior position, here we have a posterior position. So you can kind of have an idea of what I'm talking about when I'm talking about here you're going to have a sunny side up baby. Here is what we want. And then it will go through each one more in-depthly. see all the different positions baby can be in.
Just to quickly go over a secondary resource, which I feel like totally changed my world. Now, at this point, when I discovered the peanut ball, I had already used the peanut ball for years and years and years before I discovered this book. And I had already gotten Spinning Babies certified 2 or 3 times, I can't remember at the moment, for nurses. Not the Spinning Babies as an educator, but just the certification, like to go and learn about spinning babies as a nurse or in that kind of field. I think there were doulas there as well. This book, I swear, fits so well with the knowledge of spinning babies. And I'm sure Spinning Babies website has a lot of connections with what is said in this book as well. But after I read this book, I really could then visually understand positioning more. I could see it in my head when I was with each, mama coming in, trying to figure out what exactly to do, when to do it, how to tailor my care and my techniques to them. This was able to really fill in gaps that I didn't feel like I understood, such as inlet, outlet, mid-pelvis. If those terms don't ring a bell, please get this book. I will also do a video really going into describing what those terminologies mean and what this kind of book says about it. So it will be a little bit of a book review, but just absolutely awesome resource in connection with Spinning Babies. So to briefly just give you kind of a scenario of bringing all of this together, which I think is really important. How do I even connect all of this? How do I even use all of this in my practice as a nurse or as a birth doula or provider? Or how do I as a mom, how do I even make all this make sense? And when do I use this? Absolutely. Those are phenomenal questions. And I'm going to briefly give you a scenario, just one, so that this video isn't too long. But if you guys like these scenarios, I will definitely do more and more and more of them. But just to give you kind of an idea of how I'm thinking as a nurse when I walk into a patient's room. The first thing I do, obviously, is I introduce myself. I get to know them a little bit, and by that I mean about 8 to 10 minutes. And the great thing about admission questions is you can kind of have a laugh or two, or you can kind of learn a lot about each other, and you can chime in on things where you have agreement. You're really building rapport. And that's really important to do because she needs to be comfortable with you. If she's not comfortable with you, if there's anything about you that stresses her out, that can really impact her labor. So she needs to be comfortable. So that's the first thing I focus on. And I do that for about 8 to 10 minutes. And the reason I don't do it any longer is I do need to get to work. And when you're doing these techniques, you're also talking and chatting and really getting to know your patient. So that also gives you continued time to build rapport. So just to kind of give you a scenario is, let's say we have a first-time mom, she's a primip, she's getting induced for funsies, it's elective at 39 weeks, so not medically induced, it's elective. And I walk in, do my introductions, do Leopold's. Very important to know how to do Leopold's. If you don't know how to do Leopold's, you're going to end up doing guesswork, and you're going to end up standardizing your care, which, I mean, nothing against standardization to some degree on certain things, but positions are really tailored to whatever medical situation the mother's going through. But additionally, it's really important to tailor the positions to where you want the baby to go. And how do you know where you want the baby to go if you don't know where the baby is, right? Like if the baby's OP, I'm going to do something differently than, or at least some variations will be different in my tailoring than if the baby's OT or OA or ROA versus LOA. Everything kind of changes a little bit. And then you know, based on, is the baby engaged or not engaged? Sky high, low, you know, all of this impacts how you do positioning. So you really got to know Leopold's. So I'm doing my Leopold's, and then I find out, oh, baby's OP, baby's sky high because she's induced. So the first thing I want to do is, if she's comfortable with it, she doesn't have acid reflux or whatever else could be going on with her, if she's comfortable with it, I want to do forward leaning inversion. I want to do it on her forearms, so her booty's sky high, and I want to do shake the apple tree added to it. So with this, obviously you can't use a rebozo in the hospital, so I use a bed sheet, and so I wrinkle it on the sides, right above her booty, right below upper thigh area. I'm pretty sure that Spinning Babies does have Shake the Apple Tree on their website, and I will, it's the case, because Shake the Apple Tree is literally probably my favorite thing to do, especially with OP babies or OT babies. So now that we're doing forward leaning inversion, Shake the Apple Tree, it matters a lot, obviously, about monitoring. So if she has an order or any reason she has to be on continuous monitoring, you have to be mindful that when you're doing forward leaning inversion, the baby's going to be, you have to move your monitor. And then when you're doing Shake the Apple Tree, it's easy to lose that baby on the monitor because you're literally moving her, right? So, in circumstances where I'm doing continuous fetal monitoring on moms like this, for whatever reason that may exist, I'm only doing it really for probably 15, 20 seconds. Pause, check heart rate. Looks good, no decels. All right, 20 seconds, 30 seconds, everything's good. Go back to it. If mama is low risk, she can have Doppler or intermediate monitoring, then I will get a strip, a 20-minute strip before I do any of this, or, you know, sometimes orders fluctuate based off provider, and then I'll do this without any monitoring if she can be on intermediate monitoring. So obviously that's going to depend on the provider, on your situation, on the mom, health conditions with the baby, your environment, your protocols, your policies. So, and I can't help you with that. So anyway, do the Shake the Apple Tree, have her sit straight up, see what the baby does. I'm not doing Leopold's again. I don't do Leopold's very often because babies don't move usually like that. Usually I have a whole, an hour and a half, 2 hour routine of positions, consistently doing them that entire time before I would assess Leopold's again. Because I don't want her on her back, honestly. That's just not ideal. But I could do it more frequently. It wouldn't necessarily be wrong to check baby's position more often, especially if you're in a learning phase and you want more practice with Leopold's. That's probably a good idea. But that's up to your situation, and you'll have to kind of critically think what's going on in your dynamic there. So now we're in the situation, I've done Shake the Apple Tree for 20 minutes on and off during that period, right? And in that forward leaning inversion, the next thing I'm going to do is either side lying lunge or fire hydrant. So as you can tell, I am very big about leaning forward, belly down positions at this point, because that is going to help rotate that OP baby into a more of an OA situation. If you put her on her back or any back positions, that will encourage an OP baby to be an OP baby, or an OA baby to be an OP baby, and so on. So fire hydrant, side lying lunge, usually if she can tolerate it, depending on the situation, if she has an epidural or not. Well, this is an induction in this scenario, but she might only tolerate it for 20 minutes, 30 minutes. I usually do a position somewhere between 20 and 30 minutes. Now that's just my practice. I'm not telling you what you should or shouldn't do, obviously, but that's what I like, is I switch them around every 20 to 30 minutes. Now, whether you start on your right or on your left will depend on how you're trying to rotate that baby, which I'll get into more in a different video, but that's just something to think about. Is it even matters after you're doing Shake the Apple Tree? Is like, should I be doing a right side lunge or a left side lunge, or a right-sided fire hydrant or a left-sided fire hydrant? All of this matters. And so I will do those two. And at that point, I'm probably an hour and a half, 2 hours in, just doing those 3 positions. And then I may assess what baby's doing again. So that's just kind of to give you a very rough role playing of what I may be doing as a nurse in that very specific circumstances that's very general. So I hope this video helped. Please comment any questions that you may have. I would love to answer them, and I might even answer them in a following video. Thank you so much for watching. Please like and subscribe, and I appreciate your support. Thank you.